We are delighted to have with us Christopher Corless, MD and Professor of Pathology at the Oregon Health and Science Facility in Portland, Oregon. We're discussing GIST. Thanks for being with us.
Sure, thank you very much.
Based on your clinical data, what do you think the community and academic practicing physicians should be taking away from it?
So what we've been working on is an analysis of tumor samples from the Z9001 Adjuvant Trial of imatinib for the treatment of patients in the adjuvant setting. So patients who had a GIST that was 3 centimeters or larger in size and had that tumor completely resected were then enrolled for treatment with either placebo or imatinib for a period of 12 months. And what we've done now is gone back and analyzed 513 tumors from patients who were enrolled in that particular trial. Now the trial was actually closed early because it was positive in favor of imatinib and providing a benefit for patients in the adjuvant setting, and that's the reason why the drug is now approved by the FDA for this use. What we've done is an analysis of the mitotic index in the GI stromal tumors as well as the molecular genotype, that is to say the presence or absence of KIT mutations or mutations in PDGF receptor alpha. And what we found is that mitotic index is a very important prognostic indicator for those patients who are in the placebo arm. The hazard ratio was 17, and for patients who had 5 or more mitoses per 50 high-power fields, there was a considerably increased risk for recurrence. Now, looking at the 2 different arms in terms of genotype impact, we found that it was very interesting that exon 11 mutations predict for a significant benefit for treatment with imatinib, whereas those tumors that did not have a KIT or PDGF receptor alpha mutation, that is to say the wild-type GISTs, those tumors did not show any significant difference in terms of outcome between the placebo and the imatinib arms. So at this point we can say, I think with some confidence, that those patients who have a wild-type GIST probably will not benefit from 400 milligrams of imatinib treatment in the adjuvant setting. The other thing that we looked at was the exon 9 status. There are about 10% of GI stromal tumors that have an exon 9 mutation. And what we found is that we did not have enough tumors in the 2 different arms to come to any statistical conclusion as to whether or not adjuvant imatinib is beneficial for those tumors. So we're going to have to wait for further data from ongoing trials in Europe to sort out that question. But at this point we can say with certainty that mitotic index, tumor size, tumor location, and the presence of an exon 11 mutation are all predictive of the benefit of being treated with imatinib in the adjuvant setting.
So what do you do with the wild-type patients that you spoke of?
Well, I think we can say that if you're not going to treat in the adjuvant setting, then you just want to watch those patients carefully, and if they do show recurrence, then you might consider therapy with imatinib or another tyrosine kinase inhibitor.
How will your data change the approach to patients and treatment?
I think what we've learned from this is that it is important to genotype tumors, because if you're really considering the use of a drug like imatinib in the adjuvant setting, where you have to consider the costs and also the side effects, I think it is helpful to have a genotype and then be able to discuss with the patient the likelihood of benefit that they'll get from taking the drug.
Doctor, with the data you're presenting, what should clinicians think about to impact better patient outcomes?
Yeah, I think that the emphasis should be on getting a very thorough evaluation of the tumor after it's been resected to determine the mitotic index and to get the genotype of the tumor, and then make decisions about whether or not the patient should receive adjuvant therapy.
In terms of what you presented at ASCO 2010, how do you look back on it? What do you think the implications are of it?
Well, at this point, we're happy to have wrapped up the analyses from this trial, which has been going on for many years now, and we will be seeking to publish these in the near future. I think at this point we have confirmed the value of looking at something beyond the microscope, looking at the DNA level of the tumor to provide more personalized or appropriate therapy for patients.
Dr. Corless, thanks for stopping by and sharing your work with us.
Well, thank you. I appreciate the opportunity.
Dr. Christopher Corless, Professor of Pathology at the Oregon Health and Science University.